Hi guys, thank you for
I'm good. I'm good. Don't worry about that.
I know. Hi guys, thank you for joining. This is Essence of Medicine, and today we're talking about advancements in spinal surgery techniques. I'm Amanda Armagus.
And I'm Dr. Abbasi for Essence. As probably everybody know, I'm a neurosurgeon who is specialized in the minimal invasive spine surgery. And we have talked about that before, that the spine surgery is a very common procedure, actually one of the most frequently performed procedure. Amanda, you did some research on that. What did you find out?
Well, this is really old research. I haven't seen any updated numbers. I think these numbers are from 2021. So just keep that in mind because we're going to talk about how spine surgeries have advanced and techniques have advanced. But in 2021, there were over 1.6 million instrumented spinal fusions in the
And
US.
that is according to the Becker Spine, a web page that does is all about spine surgery. Now, what do you understand instrumented spine surgery? What do you think what that is?
Spine surgery using instruments.
Well, every surgery we use instrument,
Maybe
but these
okay.
are
So I
things
would
that
say
we put the
instrument inside the body and
inside of
leave
the
it.
body. We leave it inside of the body. This is what it means. Mostly, these are mostly fusion
So what's a
surgeries.
non-instrumented spine surgery?
Microdiscectomy, or laminectomy, or foraminotomy.
And those most like I think to other spine surgeons, those would be considered procedures versus surgery, correct?
No, no, all of that is surgery.
Okay.
No, the distinguishing between procedure and surgery is a very, I would say, foggy border.
Mm-hmm.
Now, generally, anything that is smaller and we don't need to put the patient sleep for it, we call it a procedure.
So what would be some
Everything
of those?
like steroid injection would be a procedure. Anything that doesn't have to be in the OR setting with a sterile field, completely sterile field, and full anesthesia is probably. But now that distinction is actually becoming more and more fluid with what we do. We do things that would be a 7 8 hour surgery and a few days of ICU stay, and in our surgery center, and patients are going home. Are they procedure? No, we still call them surgery, but they are much milder compared to how traditionally those surgeries are done. Now, so spine surgery is a very common thing, and the reason for that is that we live a lot longer now than we used to live, even 100 years ago. And our spine, I always tell my patients, our spine is made of bone and disc, and the disc are like a tire of a car that there's has a hard capsule like the rubber, and inside is a soft jelly-like material. We call it nucleus pulposus. It is like air for a tire that keep the pressure. But when we get older, that literally that tire falls apart. Now, sometimes we can make the muscle around the spine stronger, so to give it support, and it's a living thing. It often can heal itself, but sometimes imagine that the rubber is completely it's falling apart, and there are lots of hole in your tire. And imagine that you have to drive with that tire, and then you understand now that why the practically sometimes when people try to do excessive things, especially all of a sudden something happens and they are in horrible pain. And spine pain is one of the worst pain people can have. Have you ever had spine pain?
Yeah, I've had lower back pain.
Tell me about it. What?
When I'm getting my period, I get lower back pain actually. It's kind
Yeah.
of like a newer thing I've been experiencing in my body.
Is it abdominal or belly or really back pain?
Like I said, it's lower back
Or
pain.
back pain, yeah. And does it go to your legs?
Um, it it kind of is like around my butt, like kind of like around my tailbone in a way.
Mm-hmm.
And it doesn't, I mean, once in a while it has gone to my legs, like my upper legs, not my lower legs or my feet. But I think it's actually because when I'm about to start menstruating, that's just when it starts.
Okay.
I can
Now,
tell.
one of the problem with the spine is that, like, imagine you break your arm, you put it in a sling, you don't use it, and it heals. There's no position, no activity that can you can avoid using your spine. So that's one of the problem that why spine pain is so horrible.
Mhm.
And I have myself back pain sometimes that you cannot even move an inch. I tell people that there's when I have one of those flares, it takes me 10 minutes to get up from a couch or a chair.
Yeah, I've seen you when you're having those flares and you don't even stand up straight. You stand
Yeah,
up kind of like a
crooked.
yeah.
So this is a common problem. So, and often we try in our office, we try to fix it without the surgery. And sometimes, if non surgical means are not able to solve the problem, then we do procedures at first, procedures like injection, steroid injection. Literally, steroid is a hormone your body produces when trying to heal things. It reduces the inflammation, and so it reduces the pain that goes with the inflammation. As well, we sometimes just numb up areas that are painful with local anesthetic. Sometimes we do even combine them in the area that's painful, and that can help a lot of people. And a lot of my patients as well come to me and tell me, "Oh, doctor, I don't want." I send all my patients to for physical therapy. They come and say, "Oh, I'm physically active," and my answer always to them is, it's not the same. Being physically active and doing physical therapy, and even some people say, "Oh, I go to gym and so on." No, that's not all the
And
same.
actually another clarification I want to make is that
Mhm.
even if you're going like yoga, we talk about yoga a lot for the back. That's not the same as physical therapy. It's
Mhm.
actually different motions, different movements, patterns, and things like that. So even if you are a yogi, you still need to do your physical
Well,
therapy.
you think about it. This patient that they think that activity, they say, "Oh, I'm very active," or "I go to gym," or "I do this and that." Imagine in the best scenario, when you go to a gym, you get a personal trainer. They have like what 4 to 6 month training to become a personal trainer. A physical therapist goes to school about 6 years to become a physical therapist. So you can understand this is not the same thing.
Mhm.
And so, but sometimes that it doesn't even help the patient.
Yeah.
Injection, procedure, and so on. And then we have to see what is the problem. Is it a something very localized that pushing on the nerve causing the problem? Because we can go and trim it physically. A part of the disc can extrude out and push on the nerves. That gives you a lots of leg pain. That is horrible, horrible leg pain. But the problem is not the leg. Problem is the nerve that goes to the leg. In those cases, we go and trim it. And there are lots of new technologies to do that. Some of them are hypes, some of them are real. Like um, we have a saying that every few years something comes, some new thing comes, but most of them don't really catch up because they're not don't provide really help. Like in 19, I started my residency in Germany in 1996. When I started my residency, we already have a so-called laser device that for 8 years were collecting dust in a closet because people thought, instead of going and trimming what's pushing on the nerve, you can use the laser and vaporize it. And yeah, you can do that, or you can just go and pick it up and remove it, which is much faster and so on. So that was um, 8 years collecting dust already because we tried it in 80s and 70s and they didn't really help. And we said, okay, we are done. And then people here in the United States, until here, laser spine and so on, use the lasers like as if it would give any additional benefit. It didn't. Now, there is few other new things in the non-fusion, non-instrumented realm that can actually be helpful. Now, I, as a neurosurgeon, for my this kind of surgery, have been always using a macroscope, and we train with that. And certainly, that is much better than not using the macroscope because we make smaller incision, and we know with smaller incision the risks are lower and patient heals faster.
Mhm.
Um, but orthopedic surgeon they usually don't use macroscope. And in 1970s, actually, Dr. Parviz Kambin, the Kambin triangle, he found out that you can use actually the endoscope. He talked to him about 9 months before he passed away a few years back. He explained to me how he did that. He went to his urologist doctor and took his rigid endoscope, put it there, and he could see things. So that was a huge innovation, but that was completely dismissed in the United States. I probably know what happened when we invent something like electric car, and there is a huge industry that doesn't want that to succeed. What happens then?
It goes to another country, gets better somewhere else, and then we pick it up way later.
That happened to electric car. That's why Toyota is at the best in the hybrid and so on. And now we are trying to reimport that. We started that. As a matter of fact, there is a good documentary about who killed EV, electric vehicle. You watch it, then you understand. So how we sabotage ourselves. So the exactly same thing happened to the endoscopy in the United States. It went to Japan, China. We invented it. It went there. And then in the last 12 years, we are just bringing it back. Like you and I, we go to India. Every person there is an endoscopic master.
Yeah.
And here, somebody, many of those people who in the United States, they call themselves master of the endoscopy, they don't have even 1/10 of the volume of the people in India. So to be sure, if I would be doing endoscopic procedure on myself, I would go to one of my Indian friends. They are really, really good at it because they have longer and more experience with it. And by the way, it didn't go directly to India. It went to South Korea, Japan, and China. And then 10 years later went to India. And then 10 years later after that came back to the United States. So you see, we sabotage ourselves, our development with that. Now,
And also I think the hospital systems themselves are sabotaging that, because part of the reason why in India they get a lot of experience is because there's less barricades constantly than there are here in our systems. Because even if there was, like, for example, if there was an amazing technique that, like Olaf, the hospitals are still resistant.
No, I think that we have to think about it in a way that spine is a big industry. There's lots of money in it. In a way, those countries that there's not that much money in it, they're advancing faster. So let's talk about finish the non-instrumented part. So there are new method of helping the patient, and many of them were dismissed for a very long time. And endoscopy can be really helpful, especially if your alternative is those big long incision and so on. Certainly, we neurosurgeons use the macroscope. We have been using smaller incision for a long time, but now endoscopy can be very advantageous. But if you're ever looking into that, you have to know it's as well about that how much experience your surgeon has with that. And that is why our Indian colleagues are so much better. They have a lots of experience for much more longer time and so on. But there are some as well new technologies that for the decompression and so on, that the technology slowly improving. So these are legitimate things that can help patient when there is a focal, meaning very localized part of the disc pushing on the nerve. Now, imagine the disc is so falling apart, there is no future for that. Then it comes to so-called instrumented spinal, what we call procedures or surgeries. And there are two categories, so-called motion preservation, artificial disc, and fusions. Now, motion preservation or artificial disc is a little bit of a hype. Now, everybody wants to know, obviously, well, why should I lose the motion in the spine? Or imagine if my arm or my leg, they put artificial, joint there. Why not with the spine? Now, spine is not a locomotor joint. It's a posture joint, meaning that even in the best spine, the motion, range of motion in the spine is not like any other joint. As a matter of fact, individual disc has minimal motion. Just the accumulation of that from skull to tailbone give you some motion there. Now, And the proof of that is that I have done over probably 4,000 spine surgeries. To this date, 4,000 spinal fusion. To this date, not a single patient have complained that no, after the surgery they could move less than before the surgery. Okay, and patient might always ask me, if you do fusion, am I going to lose motion? The answer to that is most of the time, 99% of the time, no.
Yeah, I remember my grandpa needed a spinal fusion a while back. And my uncle, who he worked in the medical device industry, but not like as a rep or anything, just in the
Mhm.
finance section. So, in his eyes, he knew everything about medicine. He was telling my grandpa, do not get a spinal fusion. That's the worst thing you can do for yourself. And then my grandpa ended up living the rest of his life with back pain.
Yeah, and that is yet another story that's very important. And when we do those kind of surgeries, we cause a lots of damage. Those are
Not we,
massive
not
surgery.
necessarily we, right?
Well, when we as a neurosurgeon or spine surgeon, obviously, when I'm talking about that, I'm talking about traditional surgeries. Obviously, we do here those big surgeries, minimally invasively with the OLIF technique, where patient get the 2, 3 level fusion. They go home 2 hours after the surgery because we use a tube system. We don't cut the muscle, we don't cut the bone. But coming back to that, let's finish up the so-called motion preservation and the artificial disc. In certain, we have enough data to be able to say that in the neck, for not for everybody, for us, I would say 50 to 40 to 50% of the patient in within 7 to 9 years, they're as good as fusion, not better. So not that doesn't apply to all the cases, probably 40 cases or even less of the people who have neck problem, artificial disc is as good as fusion, but not better.
So, what does that really mean?
Well, after each surgery, you have concern about can you move good? Are you going to have more problem in other levels and so on? And the answer to that is yes. We hope that with putting artificial disc, we reduce those chances that other discs go bad and so on. And we have done lots of research on that, and everybody, and obviously people who are have some interest in that and they do that, they want to make people believe that that is better than the fusion. There's no hard data that they are better than fusion in any ways. I've even in the long run, there's a study came out just about 2 years ago that showed that after 9 to 7 years, the rate of adjacent segment disease, meaning other level go bad, was identical in fusion and
Mm.
artificial disc. The problem with artificial disc is what I see here is that maybe our technology is not far enough, or maybe just the spine is different. And as well, in many cases, we have seen that these patients who get the artificial disc, they have to come back, they have to fuse them, and because sometimes surgeon were too cavalier and use that on patient that they shouldn't be really even getting that surgery. Like we know now that if the spine has the disc in the front and two small joints, we call that facet in the back. If there's a problem with the facet, you shouldn't be putting artificial disc because um, imagine your door has 3 hinges and you just change one. The other two are still a problem.
Mhm.
So you didn't fix even 1/3 of a problem. Okay.
Yeah, sure.
So in the lumbar spine, in the lower back, all studies show that it's actually not as good as fusion. Fusion is better. As a matter of fact, if you remember, we went to Germany a few years back. We went to Hamburg and we did a cadaver lab and we did a lab and I was in a surgery there and so on. Dr. Demel,
Yeah.
Dremel, yeah, he was one of the original people who started this movement in Germany, and this artificial disc started in Germany with Charité and so on. In end of 1990s, he quit doing them because the people who started that for the lower back, they came to the conclusion they're not as good.
Is that where we also saw? I don't remember if it was Germany or Ecuador. Someone had like this glass case of old spinal implants and stuff, and that's when I learned about the bottle cap implant that JFK had
Yeah,
at one point,
I don't know if
and
I
it was
don't remember where it was,
unsuccessful.
but JFK did get a so-called, that was as well a German invention, but they used it here. They practically put a steel ball where his disc were, and they hope that worked. And he almost died in that surgery, by the way. As a matter of fact, his family wrote his obituary. He just no, he had other problems. He had
He had a
Addison
lot of health
disease.
woes.
He
Like
had Addison disease and so on. But that this spinal fusion that you said your grandfather was scared of it, or your uncle.
he wasn't scared of it. He was talked out of it by my
Yeah,
uncle.
and your uncle wasn't completely wrong. A regular spine surgery has 5 to 7 even risk of infection. Don't look at our results.
Yeah, but that's why the patient, I mean, that's why our health is always in our own hands. As a patient, you have to do your research not only on like the place you're going, but on the doctor themselves. And then looking at other options. We always tell our patients, look at other options
Get
first.
second opinion. They get
Mhm.
third opinion. Yes, yes. Now, so practically, the artificial disc for certain group of people are as good as fusion. There is no hard data to show they are better. Now, lots of my colleagues will hate me for that, but the data speak for themselves. Okay, you may have some data that shows they have a little advantage here and there, but if you put everything together, watch them long time, in the neck are as good for certain group of people as good, but overall not better. Now, so that is I would say a hype. But that let's come to the spinal fusions. This is where our expertise is. Now, spinal fusion in the neck is a very good surgery when your neck discs are really out of order. They are pushing on the nerve and obviously give you a lot of symptoms that cannot be controlled with other means. Now, in the lower back, this is one of the most performed surgeries. And our data show that these surgeries are massive surgeries. I'm talking about 0.24 or 0.3% of the people who die of these surgeries. Doesn't sound like much, but once you translate that to 1.6 million people get it annually, we're talking about the content of 20 jets, passenger jets, crashing and dying every year of a consequence of this kind of surgeries, ending in patients' demise.
True,
That
yeah.
is, yeah, that is a huge, and that is because we cause a lot of damage on the way of doing the surgeries. I think it is not the problem that the patient don't need that or don't benefit from that, but just doing that surgery. I mean, in this kind of surgery, we have to get where the disc is. The disc is actually in the middle of your body, and we can go from the front, we can go from the side, or we can go from the back.
Or you
But
can go from front and back.
sometimes they do that actually. Often they do that, and then you have the risk associated with going from the front and the back, and then obviously, especially when people get older, and many of these people who need spine surgery are older or have higher BMI, then the risk is extraordinarily more, exponentially more risk involved there. Now, what is now everybody's talking about is the so-called minimally invasive spine surgery. Okay, and as well, people are talking now about the robots and the navigation machines and so on, and so do that. And people who know me, they know I'm all over in LinkedIn and so on, talking about that we should not follow those trends blindly.
And yeah, and I was just going to say, and it's not because you are against trying new things or against advancements. You just need to take things slowly and really do your research, really
No, and
compare things.
for people who know me, I did those research. I'm the person who programmed those machines. I'm the person who used those machines extensively. Was the one of the innovator of those machines, the navigation machines and so on. But what I see now is that the people quit training and use the machine as a replacement for their skill rather than just using it as a tool. They say a fool with a tool is still a fool. So, and that is what I see, that now we let the fools in the OR because they have better tools.
Yep.
And that really catastrophic thing can happen. And we see that. Look up in the literature and so on. And obviously, people do not like to publish when the navigation machine went wrong. But I just was talking to one of my good friends, a young man who obviously They go now to residency. Instead of learning a skill, they learn how to be a machinist and use a machine and technician. And they use the surgery, the 3-level fusion. It was 10-hour surgery, and the robot was wrong in every single level. And I was explaining to him in what situation the robot and the navigation machine can be wrong. But yeah, if you know how to use them, if the machine is wrong, you just don't use it. You use your skills. That we have done it for 70 years.
Yeah, and if you don't hone those skills right away, or if you don't hone those skills and you
You
jump
lose
straight to
it.
robot, but if you just jump straight to robot, then God forbid something happens, what are you going to revert to?
That is why that surgery will take the 3-level fusion 10 hours. And well, Nader, this is for you. I really love what you said. When I asked you when this patient is going to go home, he said, no, this patient is going to move in. He's going to change his zip code, his home address. He's going to live in the hospital. He's not wrong. When you have a surgery that is 10 hours, just wean you from the anesthesia machine is going to be a big deal, and so on. So these patients they have to recover from a lots of damage.
Especially when you consider the age bracket for someone getting a spinal fusion
Yeah.
and then throw in all that anesthesia. When now we're learning how bad anesthesia can be for someone
For
who's
your
so old.
for your brain, yeah.
The dementia risk increases how much?
Tremendously. I mean, the numbers varies, but you have to keep the surgery for elderly short. It's not only because now the surgery has its own risk profile.
Physical trauma, yeah.
But we are not even talking about that. I mean, as a matter of fact, we have this paper that is based on 400,000 patients that every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. Imagine if surgery is 10 hours, that could be 2 hours. Imagine how many 17% are you adding to the risk of it's not like a linear thing. It's flats out eventually, but additionally, that doesn't even include the long-term mental brain dementia kind of in elderly. So the goal for the elderly is do not do any surgeries that overall anesthesia time is more than 3 hours, because that is when it really hits them hard. So, and that is the point. Those machines, like in this case with my friend, it actually didn't help them. It actually made the surgery longer. And Dr. Kim, I think, says when the hospital forced him to use that machines, because one time one of these screws wasn't perfect. I mean, God forbid, patient did great, but then every time he had to use that machine, it added 1.5 hours to his surgery, according to him.
Oh my God. Oh,
yeah.
Wow.
Yeah. And so don't get on that hype. These robots and machines and navigation, if they are used as a proper tool, they are good. But if no, this is what I recommend to everybody. If you are going to get a surgery, ask your surgeon if he's always using the navigation machine, and if ask him, would he be doing that surgery without the navigation machine? If he cannot do it without the navigation machine, I wouldn't get that surgery with that person, because this machine, if you don't know to do it without the machine, you don't know when the machine is wrong. And that can really backfire rapidly on you.
And an hour and a half is a lot of time. I think to the average person, an hour and a half really doesn't seem like that much time. But
with the gases we get, with the anesthesia machine and so on. Now, just so you know, and you have seen that here, we do a 3-level fusion in 1.5 hours and send the patient home 2 hours later.
We even do like a 1 or 2 level fusion, sometimes 30 minutes.
Yes, because and that is not just this surgeon; it's a procedure
and the team
and the whole packet that comes with that is truly a team effort. But once we are, you get through the learning curve, everybody performs that way. So navigation and robots, in my opinion, is absolutely hype, and it's a hype that is pushed by the industry to sell.
And so let's talk about neuromonitoring a little bit.
Mm-hmm.
Because I feel like neuromonitoring and navigation to a layman, it kind of goes a little bit hand in hand.
So navigation is using a computer in the OR with the cameras that helps you to understand where in patient's body you are. Well, for 70 years, we used our brain as navigation machine and the X-rays, and the surgeon was the navigation machine. My arm was the robot, and we did really well. And I take it always with me. I train it constantly and so on. And if you know what it takes, now we try to now use a computer there. And if somebody hits the part of the computer that give you localization, even 2-degree change, then can end up you being completely in the wrong place. And then now we want to use a robot and so on. And let me be very clear, even though some of my colleagues will hate me for that, is that this is an industry push to sell, not to advantage of the patient. As a matter of fact, I would never get a surgery myself by somebody who cannot do that surgery without the navigation machine.
We talked last week about lobbying. I almost wonder if there's like some lobbyists or something specifically for robotic surgery.
And you see, that is this some of this industry, and we call them evil empires. They go to hospitals and make deals with them that you cannot even use anything but what they produce, including those navigation machines. And so they kill innovation in the United States, and they were very detrimental to patient care. And the patient will feel the results of that. Like many of my patients now, they have to go out of state. They have to drive 5-6 hours to get the care because local hospital, they don't even allow you to bring new technology to the hospital. They're so in bed with these device companies that the only thing they allow is what these device companies sell to them.
Yeah, they forgot their vision. It's not really about helping and healing people anymore. It's just about making money.
Now, but there are lots of good things on the horizon, okay? Now, as you know, every time we go to India, it is like explosion of new technology that are actually human-based. What do I mean by that? In India, you and I, we were there. They cannot afford everywhere $1 million robot or navigation machine, but we show them with a handful of instruments and with training, which we provide, how they can help lots of patients so much better, so much faster, lower blood loss, like not 5% lower blood loss, like 1/10 of the blood loss. As a matter of fact, open surgery has 1,000% more blood loss than our surgeries. Like risk of infection, open surgery has literally 1,500%, meaning 15 times more risk of infection than our surgery, and so on and so forth. So and you notice that's why people are so hungry when we go to India to learn this, and we have donated our technology to them. So and you see that it comes truly to their patients' care, like with these complex cases that some of our colleagues like Dr. Praveen and Dr. Kailash and Dr. Agarwal now performing with this technology, and they can help so many more patients because risks are lower. They can in same room, same day treat more patients, and these patients they need less aftercare.
Yeah, and I think the financial strain on the patients really brings about more innovation. I wanted to talk about neuromonitoring.
Yeah, neuromonitoring is actually not like a neuronavigation or navigation and robotic where it helps you to know where you are. It is like literally putting electrodes in your legs. So when you're too close to a nerve in your spine, before you damage it, you know that nerve is stressed. And that, I do believe, is a huge value.
Especially for these countries that don't have a lot of money to spend on these bigger machines and stuff. What were you being told yesterday about local anesthesia for? Remember yesterday?
No, I don't remember. What do you refer to?
Cassandra, pause. Gupti was talking about like people are doing surgeries with local anesthesia instead.
Oh yeah. Dr. Agarwal
wait. Cassandra, restart.
Okay, Dr. Agarwal have even been able to do this surgery not under general anesthesia, but with the local anesthesia.
And can you talk about just really like literally 30 seconds? What is the difference between general and local anesthesia? Just for people who don't know.
Well, in general anesthesia, you're out. In local anesthesia, we are just numbing the area that we are doing surgery, but you are awake. We don't have to put the tube in your throat and so on. But coming back to neuro monitoring, this is a machine that, not surprisingly, in the United States, $50,000, very expensive. And every time you use it is about $1,000 to our system. In India, it's cheaper; it's about $400, but 400 US dollar is a lot there. So I think what I'm really proud of, that we could use another machine that is for plastic surgery and modified enough to be able to do this surgery. Obviously, this machine is going to be used in India and other developing countries, not the United States. But now they can have the full exposure and benefit of the neuromonitoring with a one-tenth of the price that it would be using a regular neuromonitoring machine. And we help them with that. I'm proud of that.
That's the definition of an advancement in spinal surgery, because think about how many patients just literally would not have had surgery without that.
Yeah, and I think understanding that now we don't, this is one of the problem of our surgery, because we don't open up, so you cannot look at everything of the anatomy in a traditional way. For that, you have to filo open the patient. But our advantage is that we don't have to filo open the patient, but our disadvantage is that you don't see everything. So we get lots of x-rays, which help us to see inside of the patient, and then we use the neuromonitoring, that if you are too close to a nerve, we know it, then we ease up on the pressure on the nerve. And we have been able to, with the Avicenna Society now, to create this new package of neuromonitoring that every hospital in the whole world can afford that. And that's really put a smile on my face, that we are able to help a lot of patients globally to alleviate their symptoms in a much more gentler way with this technology.
And we talk about India a lot, but it's not just India. I think right now, I know I'm going to miss a few, but we have Pakistan, India, UAE, Oman,
Sri Lanka, Bangladesh, Ecuador,
Iraq, Afghanistan.
Yeah, Iran even.
It's just all over that side of the world. Obviously, our side of the world's not in need for that.
Well, and we are not in need for that, because not that our healthcare doesn't suffer through it, because it costs us a lot of cost. You found out how many hospitals are going out of business because they cannot afford to. We cannot afford American prices, and that is why the first paper we published in our series was an economic paper to show that we can make the things more affordable for us here at home. We don't even have to help people in other places. Like when a patient stays in the OR 8 hours, well, what do you think how much it costs to our healthcare economy?
Well, I know that the OR is like $1,000 a minute.
No, it's not $1,000 a minute, but in 2015, it was $64 to $92 per minute. But if you calculate that, it's tremendous. 8-hour surgery versus 2-hour surgery, it is unbelievably different. And as well, a night in the hospital at that time was about $3,000 to $4,000. Now, instead of staying 4 days in the hospital, you stay one night or not at all. So we calculated that just by in 2015 dollars, you would benefit $3 billion, over $3.4 billion by doing, instead of open surgery, minimal invasive surgery.
And think about the impact on like the average American, because now in the US, if you have medical debt, that will affect your credit score. And staying in the hospital is very expensive.
And especially if you don't have a good insurance, and looking at the insurance market this way, even
it's expensive.
Yeah, it is expensive. The out of the pocket is just getting more and more. And now imagine the difference is if you can go back to regular life within weeks or within months and months and months. And that is that the true innovation comes, that shorter surgery are more efficient, are less damaging by all categories that we have looked at. But as well, they put you faster back on the track to go back to your life.
Yeah. Psychologically too.
Psychologically, financially, healthcare wise, and so on and so forth. And I think now, but we have to as well talk about the lots of hype in minimally invasive, because we have a joke among spine surgeons that we say Every surgeon likes to call himself a minimal invasive spine surgery, or call what they do minimal invasive spine surgery. Like they open up your belly and put all the guts out, and they call it minimal invasive spine surgery. It is a term that has not been unified about. But ask your doctor, how many of these have you done? How long usually do I stay in the hospital? As a matter of fact, if a doctor that you get any kind of surgery doesn't explain that to you, go get a second opinion, third opinion. As a matter of fact, if they don't like you to get a second opinion, it's even more reason to get a second opinion. But you need to understand how long do you stay in the hospital with that, how much is the average blood loss, what is the risk of infection. These are the established safety record of any surgery.
Mhm.
But in spine, they become really crucial because that's what's going to make a difference. Spine surgery has a really bad reputation for a good reason. This is not your uncle was not wrong to and I get many patients that they say that they have been scared of getting spine surgery because the reputation of the spine surgery, and we cannot dismiss that the traditional spine surgery is not a shining star of medical field.
Yeah.
But that makes me even more excited about that because we changed that equation. We did change that equation.
Yep.
Well, what else do we need to talk about?
I think we covered a lot of stuff regarding innovations in spine surgery.
Okay, well, thank you very much.
Thank you guys for watching. I'm Amanda Armagast.
And I'm